Welcome. I'm really glad to be here. I hope the volume level is right. And here's what we're going to do, talk about these kinds of things. And amidst what could be a day-long, if not week-long or month-long workshop on ADHD, we'll scratch the surface of what I think are a few key issues, and then I hope you stick around for discussion, which we want to have plenty of in under an hour's time. So I'll talk a little bit about prevalence and what's going on around the country and a little bit the world in terms of the increasing rates of diagnosis of this condition and some rather huge disparities between states, between socioeconomic status groups, between countries in how this condition is diagnosed and treated and what implications for policy might be. We'll talk about ADHD a bit across the lifespan, raise some key developmental issues. We'll of course talk about what might be causing the symptoms and impairments, what the mechanisms might be. This again would take much more than the time we have to even get into this subtopic. And we'll finish with a review of what we know about what works for ADHD, what we hope to learn in the future works long-term for ADHD, because the best evidence-based treatments to this day don't really maintain after the last dosage of medication or the last behavioral contingency has been delivered. So we have a big gap between short-term efficacy and the long-term rehabilitation we'd like to do. And again, discussion at the end. So please stick around for that. And if you look at op-eds and read the web, a lot of people out there say ADHD isn't real, it's just America's concern with conformity, and we're labeling kids who are simply bothersome. But as we'll talk about today, ADHD is quite real. It's been around for a long time. It appears in every culture. One thing we're not going to do is really an assessment workshop, which measures work best to help get at these symptoms and impairments. But a real moral is that in practice around this country, ADHD is often diagnosed and then a prescription written after about a 10 or 12 minute office visit in a pediatrician's office. And that's a recipe for overdiagnosis and underdiagnosis. This is a careful workup that's needed. Again, we can talk about some of this in the discussion. One of the big issues the clinician has to deal with is that the symptoms of ADHD are the symptoms of being a 2 or 3-year-old boy. ADHD is early boyhood brought a little bit later to life. The symptoms are not grossly aberrant or unusual the way they are for some of the symptoms of autism or other developmental disorders. So development has to be part of this process, knowing the child's age, the child's gender, and where on the developmental curve these symptoms are presenting themselves. Back in the day, in the 50s, when Herb Quay and others were bringing modern factor analysis into child psychopathology, a bunch of symptoms related to inattention and impulse control and hyperactivity loaded on a factor in these early child psychopathology scales. And the name given to the scale was the immaturity factor, well before ADD became a gleam in DSM-3's eye, et cetera, et cetera. So there was clinical recognition and research recognition that the symptoms of this condition may reflect a kid who's acting younger than his or her chronological age. And we'll raise immaturity expressly when we talk about some neuroscience, neuroimaging data a bit later in the talk. Now, jamming a lot onto each given slide, what if a child has or adolescent has a valid diagnosis of ADHD? What do we know? We know that there is high likelihood that that individual is going to have trouble in school, all kinds of trouble in school of varying degrees. We know now from random phone dial surveys and other EPI surveys that the cost to the US economy each year of adult ADHD is measurable in the tens of billions of dollars. Underproductivity, unemployment, stuff not getting done at work. So the cost of this condition is grave across the lifespan. We know also that if you had to pick a developmental condition, a diagnostic label, and say which among these many conditions do peers, other kids that kid's age, dislike the most? ADHD would be the right answer. Kids with ADHD, on average, are less liked than autistic kids or depressed kids or delinquent kids. And as we'll talk about, if you still had in your assessment battery one measure, so you're allowed, could be a doctor's report, could be a checklist, it could be an educational evaluation, one measure in about second grade to predict who's going to drop out of school before 12th grade, who's going to end up in juvenile hall, or who's going to need mental health services in their 20s. What would that measure be? How rejected is the child from his or her peers in second grade? Longitudinal studies, some done 40 years ago, show that consistent in the early elementary grades, peer rejection, kids saying, I really don't like this kid, I don't want him or her to be my friend, is the single strongest predictor of those serious developmental outcomes, dropout, delinquency, mental health problems in the 20s. So if kids with ADHD are really disliked, peers are a good early warning system for helping us to know that. And we're going to have to treat peer-related problems. As we'll talk about, ADHD seems to be fairly highly genetically mediated. But that doesn't mean that families aren't important in terms of interactions. In fact, as I'll show you at the end of the talk, some data that our group published on the basis of the MTA trial shows that despite the high heritability of ADHD, family interactions may be quite crucial for outcome. We know that kids with attentional and impulse control problems during preschool or now age 16 and above are highly likely to have accidental injuries. This goes to motor vehicle accidents, this goes to emergency room visits earlier in life and later in life. So to me, this is a key point against those who contend we're just labeling bothersome children. There are risks to health from these symptoms. We know from a couple of studies done in the 90s that if you have ADHD despite having a normal IQ, your independent functioning, as assessed by scales that were initially used to assess kids with autism spectrum disorders, places you in terms of independence in the mildly mentally retarded range. So you're not doing the things in terms of life skills and independence that not only your peers can do, but kids much younger than you can do. So ADHD has consequences for shifting out of adolescence into adulthood with a full set of independent life skills. Now, for a moment, just back on two of these, various indicators of school functioning, grades, achievement test scores, whether you pass or retained in a grade, are highly related to ADHD, regardless of whether you've got other comorbid conditions along with it. We know that if you had to pick a category that predicts having trouble finishing school, ADHD is probably the top pick as well. It's the kids with ADHD who are also labeled with ODD or CD, the externalizing aggressive spectrum. They're the ones most likely to get suspended, expelled, etc. If you go developmentally, and this will just be a very quick point we could pick up on later, what is salient in a 3, 4, or 5-year-old to predict later achievement problems? Inattention symptoms rated by the preschool teacher, as well as even subtle speech and language delays and problems, are outweighing many other factors that we might think of as quite related to school achievement in the grade school years and beyond. And again, just another point to reinforce what I said about the social and peer domain. Kids with ADHD were described by my graduate school mentors, Carol Whalen and Barbara Henker, as negative social catalysts. You put them into the chemical reaction of a peer group and they'll make something happen, usually with smoke and fizz and explosions. These are social kids. They want to be engaged, but following the social rules, reading facial cues, knowing how to regulate behavior, and the classic story is a true one. These are the kids who blow out the candles, but it's not their birthday party. This is not a good way to get along with a peer group. The inattentive type that we'll focus on a little bit later, the kids with ADHD without salient hyperactive impulsive symptoms, tend to be the kids who fall by the wayside in the classroom. They're the ones whose classmates say, oh, was she in my class? I kind of don't remember her. More ignored, which is not a good social fate, but they're not as overtly rejected as kids with the more hyperactive impulsive symptoms, what we often call the combined type of ADHD. And just reinforcing the point from Emery Cowan's work and others, peer rejection, consistent dislike in the early elementary grades is a huge predictor of later problems. Meaning what? That we should be hiring elementary school kids on our assessment teams, because they're good at noticing, but also that the act of being rejected by your peers, of being disliked, is part of the causal process. It's like being expelled from peer school. How do you learn the social skills if kids aren't inviting you to subsequent birthday parties, play dates, et cetera, et cetera? ADHD, as we'll see in a moment, goes along with many other kinds of conditions. But if you look at these domains we're talking about, where these kids end up in trouble, the ADHD symptoms predict impairments above and beyond the comorbid conditions that go along with ADHD most of the time. ADHD, as we'll talk about, is not a disorder. Now, I'm not making a political statement here. I'm making a statement about every entity in the DSM. A disorder is a syndrome with an underlying unifying cause. ADHD is a syndrome. These are symptoms that go together in the same kids at the same time, but we know of no single underlying cause for ADHD, putting it in the same league as all other neurodevelopmental conditions. This is a syndrome where there might be multiple causal paths. Now, if there's more time in the formal talk, we talk about girls with ADHD. Our research team has a large sample of girls with this condition. We assessed them and ran summer camps with them back in the 90s. We just finished a 10-year follow-up. We'll certainly be glad to talk about that in the discussion period. But is it the case that if we just looked hard enough, there's as many girls as boys with ADHD? And the answer is, in a nutshell, no. Like autism, like early onset conduct problems, like some forms of learning disorders, ADHD is a male predominant condition in the early part of life. Many reasons posited for this sex imbalance of all early onset neurodevelopmental conditions. What do we know? A, girls can and do get ADHD, in many cases looking just like boys with this condition. 2, girls are relatively more likely than boys to have the purely inattentive form. Most girls out there with ADHD have the combined form, but a larger plurality of girls than boys have the inattentive type, which may have some long-term implications. In fact, these are not prospective studies, but if you go cross-sectionally now to adult ADD clinics across the country, who comes to them? About half men and half women. Now, maybe women are just more honest about their symptoms. Maybe women are more likely, as we just noted, to have this inattentive form. The inattention symptoms stay fairly level across life. The overtly hyperactive impulsive symptoms show a big decline in adolescence. So maybe it's not just women's greater honesty, but women have the form of this condition that's more likely to persist over time. Many more things about girls with ADHD, most of them we'll probably have to save to the discussion. Now, on your continuing education quiz, in order to leave the room, you must pass. There are some percentages of comorbidities I'd like you to memorize now. And this is just obviously for your information, but a big issue in assessment is it ADHD or a kid who's been traumatized? Is it ADHD or maybe a minor motor seizure disorder? Is it ADHD or pure anxiety for the inattentive type? So there's differential diagnosis to make, but there's also comorbidity. The vast majority of kids with ADHD, not just clinics, not just in clinics, but in the community, have other conditions, 1 or 2 or 3 or more of these below. And this is sort of gleaning from the literature, the average percentages of kids with ADHD who also have oppositional defiant or conduct disorder, anxiety disorders, depression. Note for bipolar disorder, there's a range from 0% to 20%, making this an area of huge contention. Most standard bipolar interviews, if you interview kids and families, kids with ADHD, they don't show up with classic bipolar disorder. Or is early onset bipolar disorder pretty different from the classic adolescent or adult onset? Is it more chronic and less cyclic? This is a huge controversy. Be glad to discuss later on, with big implications for treatment. If a kid with ADHD really has a potentially psychotic disorder like bipolar, should we be giving him or her stimulants? Probably not, one would say, although the data currently suggests that many kids with ADHD and bipolar symptoms do very well on stimulants for their ADHD symptoms, and we have so few clinical trials of the anticonvulsants and antipsychotic meds used for bipolar disorder in kids. Huge area of controversy. Won't talk about the others in interest of time. So let's go to the real world. Let's go to policy a little bit. If you've been reading, following with the Centers for Disease Control, what happened against all odds in this past decade? The prevalence of ADHD, the diagnostic prevalence, the percentage of families and random samples who said, my kids had a diagnosis of ADHD, went up again. 2007 data, just published 2009-10, 9.5% of all kids in the US had a diagnosis of ADHD. If you look at DSM-4, way back in the mid-90s, it says it's 3 to 5%. That's way out of date in terms of diagnostic prevalence. And if the 3-to-1 ratio is right, that's about 1 in 7 boys who've had this diagnosis. Is this a true increase in prevalence? Is this physicians, largely pediatricians, also psychologists, making this diagnosis more? Huge questions. By 2007 and 2008, about 66% of kids with this diagnosis had received at least one trial of ADHD medications during their life. And that's way up from a third or fewer in the 80s and 90s of kids with ADHD who ever got a medication trial. So medication rates are increasing, as is the diagnostic prevalence. At lunch with the fellows and trainees, we did a little quiz. What was the biggest year in recent history of an increase in prevalence for ADHD in the US? And the year was 1991, because in 1990, in November, Congress reauthorized the Federal Special Education Act. And under the new IDEA provisions, ADHD for the first time was included as one of the 17 other health impaired conditions that could land you special ed services. The next year, the diagnostic prevalence of ADHD went up by about 35%. So policy influences where people go for services and what diagnoses they get. But despite that, the increase has been almost linear, even in this past decade too. Now, those are average statistics, but the average, as it often does, is suspect. If you look at these recent CDC data, 17.5% of all kids in North Carolina had received a diagnosis of ADHD. That's about a quarter of all boys. The rates in Nevada were slightly under 5%. That's a big disparity. What's behind that? Is it the water supply of Nevada versus North Carolina? I don't think so. Is it the ethnic composition? Is it the mix of providing professionals? Is it school classroom issues? In some of the policy work I'm doing now, very much a neophyte in that, my colleague Richard Scheffler, a health economist at Berkeley, and I are in the throes of writing a book about policy, ADHD, and medication to try to get an answer to some of these questions. What about medication? If you had a map of the states, which I saved some slides in interest of time, the southeast US, about 80% of the kids with a diagnosis get medication. But in California and Nevada, it's under 50%. Now again, is that because of larger Latino population in California? Latino and black kids are less likely to get medicated than white kids. Is it a reflection of different values? Is it a different state insurance? We're trying to sort this out. but the real world of ADHD is as intriguing, if not more so, than the neurobiological world, and it's really important to look at both. Is ADHD just a US thing? Are we just sort of tired of our non-achieving kids and we've got to have everybody above average? ADHD in countries where there's compulsory education exists at pretty alarmingly similar rates. The Polanczyk Review in the American Journal of Psychiatry back in 2007 showed that the biggest differences, why the US has more and other countries a bit less, have to do with the diagnostic system they use, not so much cultural differences per se. So it's safe to conclude these days that ADHD is not just a US kind of thing. So you can tell by the change in color we're off to a different topic. Let's talk for a few minutes about what people think might underlie this condition. If you were assembling a melange of developmental models, ADHD would be the poster child. Every developmental stage, every part of the brain, every type of motivational, relational learning model has been proposed. We still don't know enough to know what the right models are. Lots of attention in the last 10 or 15 years have gone into cognitive and cognitive neuroscience models. As the name implies, attention deficit hyperactivity disorder with the ADD part of it. Maybe this is a disorder of sustained attention. Or it's not so much attention, it's the ability to withhold that impulse to, because you're hungry right now, rush out for dinner, but no, it's better to stay in the room till 5:30 or 6. Maybe it's the inability to hold off on that previously rewarded response. Or maybe it's a working memory problem, the ability to hold a number of pieces of information or spatial kind of maps in your mind simultaneously. All of these examples in this large bucket of things we call executive functions or sometimes cognitive control. The problem is that sustained attention, selective attention, attentional span, as well as these other constructs in the EF category, none of them pertains to all kids with ADHD. Executive functions are not one and the same. There are kids with ADHD diagnoses who are pretty rambunctious and difficult to deal with who don't seem to have executive function problems. So this is a partial explanation. With Megan Miller in the audience here today, who works at Berkeley and here at Mind, her master's thesis now published showed that in our girl sample, deficits in these key executive functions during childhood were predictive of academic and social and global impairments in adolescents, but not just in the ADHD girls, in the comparison group as well. So again, may not be entirely specific. Not being able to sustain attention, control impulses, plan, set shift, these functions are crucial for developmental outcomes across at least ADHD and comparison kids. Or is ADHD really not so much a cognitive disorder, but it's a motivational disorder? There's problems with attending to rewards and regulating behavior in that way. Been a lot of talk of this over the years. The key study I'd point you to is Nora Volkow's study, she's the director of NIDA, with Jim Swanson and colleagues, just published in JAMA a year ago fall, where it took them 8 years to gather about 75 adults with classic ADHD who'd never received a medication in their lives. And it was very crucial for the methodology. There was a medication-naive sample. And this was a PET study, and with PET scanning, you're able to localize where the radioactive tracer lands on, in this case, dopamine receptors and transporters. And here are some numbers, and here's a little bit of a picture with the numbers. What does this mean? The medication-naive adults with ADHD had significantly fewer dopamine receptors and dopamine transporter molecules in the key reward system of the brain, the nucleus accumbens and the related reward pathway way subcortically. Not so much in the control areas. Also in the caudate part of the frontostriatal pathways seem to be linked to attention. Now you could say that makes sense in terms of dopamine receptors. If there's not as many, then a stimulant medication would up the level of dopamine and get those receptors stamped. But you'd think maybe in terms of transporters, the molecules presynaptically that get the neurotransmitter back in the cleft, that there would be more of them, but there were actually significantly fewer of them too, proving that things in the central nervous system aren't as simple as we first think, and that when a medication works behaviorally, it may not be its initial effect on increasing dopamine flow or blockading transporters. It may be second level up or down regulation, and third level actually gene transcription effects postsynaptically. Things get more complicated the more we know. But this is strong evidence that there is a big reward motivational component, at least in adults with ADHD who've never been medicated. So the models that the textbooks talk about a lot today, Virginia Douglas's self-regulation model, it was on the basis of her research that hyperactivity got renamed as ADD, attention deficit disorder. Joe Sargent and the Dutch colleagues of his talking about cognitive energetic resources. That's motivation, it's cognitive control put together. Russ Barkley is best known for his ADHD model saying it's not attention per se, it's response inhibition. But in his model, if you fail to restrain that impulse, then you also fail to invoke 4 crucial executive functions half a second or a second later. So his model is really not just inhibition, it's an executive model too. With the explosion of research on cognitive motivational models of ADHD these days, the need for consistent test batteries, for normalizing protocols for brain imaging is huge, the way it is in many other areas of research. So what's going on upstairs in the brains of people with ADHD? Again, we could spend all night talking about the huge explosion of studies in the last 10 years. At an overall level, if you're looking structurally, brain volume, brain regions, people with ADHD have lowered overall cerebral volumes compared to controls. Is that causal? Is that related to the somewhat lowered verbal IQs? Unexplained question, but it's been replicated many times. The caudate in the cerebellum, not in every study ever done, but in many studies, although sometimes it's right versus left, the failures to replicate are huge, seem to be smaller as well. The big research that's sort of caused an explosion of interest isn't so much about overall volume, but it's about cortical development. And this is Shaw's work with the NIH group. The big study came out in 2006, a less known follow-up in 2009 into the end of adolescence. What was the bottom line here? That we know through normal development, the cerebral cortex, the few millimeters of our sort of vital part of our brains, undergo regular changes in thickening and then thinning, the thinning being related to pruning. Kids with ADHD are about exactly 3 years lagged. They show a developmental immaturity. So back to the early factor name, maybe there was something more than just descriptive going on with that. If you look at the follow-ups into later adolescence, when more pruning is coming, kids with ADHD still stay a few years lagged compared to comparison kids. Now, as some people said when this research came out, well, this means that kids with ADHD don't really have a fundamental deficit, they're just a little bit delayed. And Shaw himself said that's not true, that 3-year lag may be crucial for all sorts of functions that the brain does. If you go to fMRI, if you're looking at where the blood is going as the brain is involved in tasks, if you go to DTI, looking for actual pathways, most evidence, and this is probably the most replicated finding, is that people with ADHD are less efficient in these pathways that go from the frontal lobes back to the striatum. These crucial pathways for attention and self-regulation. Until recently, it was thought that, well, the only way to really study this is to get people with ADHD engaged in a working memory task, or to get them engaged in a sustained attention or a response inhibition task, and look at their brains during the process. There's been an explosion, as many of you know, in recent months and years in so-called resting state neuroimaging. What do the brains of people look like when they're kind of hanging out? not doing much of anything. We won't say that's the status of you during this talk, because of course you're all actively engaged, but after the talk, if you're just sitting there hanging out, and Castellanos' work at NYU has been quite revealing, just even in recent months, that there are reliable brain differences between people with ADHD and without, even in a resting state, when people are asked to sort of sit and hang out and just think of whatever they're thinking about during the day. So there may be some markers that aren't specifically related to performance on one of these executive tasks. So, new color, a little bit about etiology. What do we know from twin and adoption studies? That the risk for ADHD is carried largely in the genes. Heritability of about 0.75 or 0.8. If you look at the studies of ADHD, the behavior genetic studies, that use teacher ratings rather than parent ratings. So in most twin studies, the parent says, hey, they're identical twins or fraternal, and the parent rates the symptoms. But if you use teachers, the heritability estimates go down substantially to 0.55 or 0.6. So there may be some contrast effects in the typical behavior genetic twin study. Nonetheless, it's a pretty darn high heritability. The reasons why attention and impulse control, why people differ in them so much, are largely genetic reasons. So of course, parents don't matter. The kids are born this way and there's nothing to be done about it. If you're awake by the end of the talk, I'll hope to convince you that's not the case at all. And even though we could lecture a long time about heritability, how much of individual differences are contributed to by genes, if you haven't read this, go get a hold of Eric Turkheimer's work, University of Virginia, who's analyzed the heritability of IQ scores in large samples. And what does he find? Heritability differs dramatically across SES. The heritability of IQ in the wealthiest kids in the families is 0.8 at least. The heritability of IQ in the poorest kids is about 0.3. Heritability, remember, has to do with genetic variance and environmental variance. Given the huge environmental variance and many psychosocial deprivations of poor kids, environments contribute more for them to IQ than they do for kids in the relatively homogeneous upper middle class SES. So heritability is not fixed, just something to keep in mind. What else do we know? Low birth weight is a risk factor for some specific developmental conditions. ADHD, reading disorder, math disorder, Tourette's, cerebral palsy, and extreme low birth rate, mental retardation. Not depression, anxiety, conduct problems. So here's a non-genetic pathway caused by premature and particularly low birth weight that has influence on the developing frontal striatal network. Until about the 6th month of gestation, there's one cerebral artery that perfuses these developing frontal and striatal areas. Early birth, low birth weight kids often bleed from that artery, and this may be a precursor of later ADHD. What about teratogens? What about alcohol? Fetal alcohol syndrome leads to severe mental retardation, facial dysmorphisms, but there's a pretty linear dose response, such that any amount of alcohol a woman ingests, all the way to a lot, predicts fetal alcohol spectrum disorder, fetal alcohol effects. And what are fetal alcohol effects? Inattention, impulsivity, hyperactivity, aggression, and learning problems. So there's an unknown number of kids with ADHD who, in addition to whatever genetic vulnerability they have, may have been doused with just a little more gasoline, if you will, by the alcohol ingested early on. Several studies in the last decade show that tobacco use in parents, in moms in particular, but also secondhand, predicts ADHD and oppositional defiant disorder. Some studies find that there are confounding factors in the home. Others, taking into account all those confounders, show a specific link. But we all know that ADHD is caused by that mom in the Safeway who's neglectful of her kid or smacks the kid. There's no consistent evidence that parenting practices are specifically correlated with the classic inattention and impulse control symptoms. In fact, if you go to an attachment model, there's no relationship between early insecure attachment and later ADHD. Now, where's the studies that show that? Well, those studies don't get published because the big attachment studies within the last 20 years didn't publish findings saying no link between insecure attachment and ADHD because they didn't find it, and there's publication bias. What about early insecurity of attachment and later aggressive spectrum disorders? Huge effects. 75% of ODD kids have histories of early insecure attachment. You can predict backwards and forwards. So a tentative model would be ADHD is neurocognitive. It's not so related to separation, attachment disruption, but this comorbid aggression is, so you can see why some families would have both risks. However, Carlson and Sroufe back in the 90s in a high-risk sample in Minneapolis showed that during the first 18 months of life, moms who were pretty insensitive to their infant's cues had kids who later showed not ADHD diagnoses, but ADHD symptoms. This hasn't been replicated. Was this particular to a lower class sample? We're not sure. We also know from the major studies done in the last 10, 15 years with Romanian orphans and other Eastern European orphans that early deprivation, being in some of those horrific slatted cribs with hardly any stimulation in the first few years of life, predicts what as a primary symptom? Inattention and overactivity. But the inattention and overactivity exhibited by such deprived orphans comes with often indiscriminate friendliness and a real attachment flavor to it. So it's the same symptoms on a checklist, but it's got a different clinical feel from the ADHD we'd see in American classrooms or other European classrooms where kids haven't been deprived. So if you're a student of developmental psychopathology, you'd say there's equifinality. There may be several different, very different causal pathways leading to, at age 8, 10, or 12, what seem to be the same kinds of symptoms. So what's the cause of ADHD? We talked about it at lunch, compulsory education. It's true. There's a little bit of tongue-in-cheek in here, but the genes that seem to be responsible for attention and their various allelic forms, they didn't start in the 1850s, 60s, or 70s. They've been around since we've been a species way before. But until we had kids do things that our brains didn't evolve to do, like learn to read and sit still for hours a day, the symptoms that might be mediated by those genes weren't very salient. So the cause of ADHD is the cause of learning disabilities, which is compulsory education, meaning that it could be all neurobiological and all cultural at the same time. It's not one or the other. So we promised to talk a little bit about development. Let's say a few things. So ADHD would be related to the temperamental dimension of activity level, high activity level in the first months of life, right? The predictive studies aren't terribly clear. What's much more predictive in the limited research is the temperamental facet called effortful control, which comes online late in the first year of life and on into the early second year. Girls are much higher in effortful control than boys. Effortful control seems to predict the later symptoms we're talking about. Can you diagnose ADHD in a 3 or 4-year-old? It would be great to, because you could do early intervention well before formal grade school has started. Probably the world's expert in this is Sue Campbell at Pittsburgh, who's assessed literally thousands of preschoolers, very careful assessment, hours after hours, multiple informants, attachment paradigms, parent-child interactions, and has published a number of papers on this validly diagnosed group of preschoolers with ADHD and following up to see 6 years later, 10 years later, who's got ADHD? Who was a false alarm and who's not? So, first question, what's the positive predictive power? What percentage of the 3 and 4-year-olds with ADHD had ADHD by the end of grade school? The answer, about 50.2%. So she made up the numbers, it's half and half. So let's stereotype a little bit. The pediatrician who says, he'll grow out of it, is wrong half the time. The other pediatrician who says, let's get the Concerta script written now, is probably over-medicating half the time. What you'd really like to know is what differentiates at 3 and 4 those who progress into the full diagnosis in the grade school and those who may still be more rambunctious than normal but don't have formal ADHD. 2 predictors. Number 1, you didn't need to come to the talk today to learn about, which is how severe were the symptoms at age 3 and 4. The kids who had all 18 DSM symptoms, or all, however many there were in DSM-3R, the top of the chart predicted the top of the chart. There's stability of these symptoms. But the second predictor was quite intriguing, statistically controlling for the severity of symptoms. How negative the parents got with the kid in the playroom, controlling for how much of a pain the kid was on the ADHD symptom chart, predicted the persistence of the condition over 6 or 8 years. So there's something about probably those parents didn't cause those symptoms at 3 and 4, except maybe by the genes they contributed or the teratogens or whatever. We could make that argument, but how the parents respond to those early symptoms may have a huge difference for outcome. Certainly has a difference for comorbidity in outcome predicting ODD and CD. So there's a clue there that parents may matter not as ultimate causes in a psychosocial sense, but in terms of maintainers, or maybe in terms of turning the tide around. So just tell you a little bit of research we did. This is a couple of studies back in the 90s with some of our boys' summer camps, and without reading slides, we'll just go to the data. We had a number of boys with ADHD and a matched comparison group of boys without. These are all kids 1st to 6th grade. Many hours of assessment were pretty clear they had ADHD. We also videotaped them playing with their parents in the playroom and having the parents do classic tasks with them, free play for a bit, then do some homework and then clean up the room. Everything's fine during free play, then the parents ask them to do homework and clean up the room, and all hell breaks loose. That's when you really see the difference. And we had our coders, one set of coders coded in that interaction the level of non-compliance and negativity in the boys, in each boy interacting with his mom or dad. And then another set of coders coding a number of things about the parents. The biggest bang for our buck was with, because we had 100% of moms in the study, maternal negativity. Did the mom yell and scream, grab stuff from the kid's hands, and use kind of sarcasm and derisive comments? So the sum of those was the maternal negativity variable. This all happened in the spring. The kids come to our 6-week summer camp. We observe them every day. We also did a little assessment at the end of the camp that I thought up back when I was a beginning assistant professor, which is to see how much the kids would steal from us when they were in a little temptation room the last week of the camp, when they were supposed to be doing work on their own, but there was a little money lying around in markers and they could deface the room and things like that. Very predictive measure. It's our single best predictor of delinquency 10 years later, was whether they stole or destroyed property in that 6 minutes. Sort of amazing. What did we find? The kids' level of negativity interacting, in this case with mom, predicted a little bit of the variance of how much that kid stole from us. The mom's general distress, anxiety, depression, etc., predicted a little bit. How negative the mom was with her son, controlling for how much of a pain in the neck he'd been with her, predicted 10% of the variance in how much he stole from us. So the maternal negativity, the responsiveness to this difficult kid, didn't predict ADHD symptoms, but predicted the comorbid, covert antisocial behavior. So parenting may matter more than we think for a so-called heritable psychobiological condition. And another study we did, summing across many of our boys' camps, we said, what's going to predict, because at the camps every week we'd have the kids rate one another and sociometric interviews, who was popular, who was really well-liked. And so we were going to put in the equation the behaviors they display each week and all kinds of things. And as an afterthought, we put in the equation how the parent rated himself or herself on authoritative parenting. authoritative parenting, high warmth and high limits, and a lot of encouragement of independence. Now, the worst way to measure parenting is through a self-report checklist, because I've never been inconsistent with my boys, and I've always delivered rewards, and that's what I said on my checklist. However, this scale, the Ideas About Parenting scale, Dinah Baumbrand, Phil Cowan, Carolyn Cowan helped develop this. Harder to know, harder to fake good on this. There are a lot of interesting questions on it, and we got a very clear authoritative factor. There's some of the items on it. What did we find? First of all, this is again moms with 100% of data, dads are sort of parallel. The moms of the boys with ADHD were a lot less authoritative than the moms of the comparison group. Warm, encouraging limits and independence for my kid with ADHD. It's a miracle we survive homework every night. This is tough going. We haven't had a good interaction in some years. However, the variance of the ADHD group was quite big, just as big as the comparison group. When you get variance, you might be able to predict something. What we found was that how aggressive the boys were during the camp, how much they stole, how much they were anxious or depressed, none of that really mattered to how well liked they were. What mattered was, did the moms hold on to authoritative parenting beliefs? Now, we didn't, for some ethical reasons you might understand, randomly assign certain kids with ADHD to live in homes for 10 years with certain kinds of parents. It's a hard sell to your IRB. So it's a correlational study. Nonetheless, this held for our non-biological as well as biological families. If you're swimming upstream and have a kid with ADHD, a boy in this case, who's hard to deal with and hard to be authoritative with, but you can somehow maintain those warm, limit-setting, encouragement of autonomy beliefs, you've got a kid who is liked by his peers. So it's a clue that social competence may be linked to some home variables. How many kids with ADHD grow up to be adults with ADHD? And it turns out that's an intriguing trick question, because it depends on whom you ask. In Barclay's Journal of Abnormal Psychology study, published almost 10 years ago, in the Milwaukee sample of about 170 boys and girls, by young adulthood, if you asked the young adult on a structured interview, ADHD questions, about 4% of the sample had ADHD. That's not very many. If you asked the caregivers, who some of them didn't even live with their kids anymore, that number went up to 46%. And if you asked the caregivers but modified the ADHD symptoms to be more developmentally appropriate, it went up to about 70%. Don't trust people with ADHD to report on their own symptoms. You have to get informants in the assessment process. This is true for bipolar and mania, it's true for ADHD. Intriguingly, in some of the recent follow-up that Barclay's group has done, when these same kids in Milwaukee were now 27 to 29, their ratings were corresponding with caregiver ratings much higher than ever before. Is that because their frontal lobes had finally matured by 25 to 28? Is that because they've reached a stage of honesty in their lives? We're not sure, but it's intriguing. Russ has posited there should be a different set of adult ADHD symptoms in the DSM-5. Here's his tentative list that's being debated right now. So we're going to finish up with a couple of points on treatment. Of all the things you might do, and here's a list of either unproven or partially proven treatments. Go to any website, you'll see lots of intriguing other treatments too. What are the only two evidence-based treatments for ADHD? Medications and behavioral therapy. The combination of the two could be a third. What do you have to do, whether you're a psychologist working with a family and parent management, whether you're an MD prescribing medication? You've got to get data on how the kid is doing, which is hardly ever followed in practice. Brief ADHD symptom scales. Teacher can fill them out once or twice a week, parent once or twice a week. Plot the data. You don't know what the dosage is until you've tried several dosages. A kid might not respond to medication 1, but might respond to medication 2. Seems simple, but it's not followed in practice. I'm going to talk about the big study that we at Berkeley and 6 other centers around the country and Canada did. Back in the 90s, the MTA, the multimodal treatment study of ADHD. Here also for your quiz at the end is, of the 579 kids who entered this trial, they all had combined type ADHD, 80% boys, 20% girls. Only 179 had ADHD as the only diagnosis. And some had 2 diagnoses, or 3, or 4, or 5. You can count in the middle of the Venn diagram there. So ADHD is complicated. What did we find? I'll go to a graph. After 14 months of very intensive treatment, either medication, the dosage got right, and then a monthly visit for 30 minutes with the doctor, or very intensive behavior therapy, 35 parent training sessions, school consultation every other week, a summer camp for the kids, an aide in the classroom, the combination of those 2, or random assignment to community care. What delivered the best outcome at the end of treatment? It was the combination. If the outcome is reduction in ADHD, ODD, and anxious symptoms, and improvement in school, peers, and home functioning. For the symptoms of ADHD alone, medication did just as well as the combination treatment. But if you wanted to get at the functional impairments, the combination treatment pulled away. However, it's a little more depressing than this. We published a paper a few years ago in Journal of Consulting and Clinical looking at what might moderate that. So, just to walk you through it quickly, the kids who got medication or the combination, in terms of getting rid of their ADHD symptoms, 62% of them showed a good response. The kids who got no medication at all, or medication in the community, only 30%. But among that 62%, what did we find? If before the study started at baseline, the primary caregiver had even mild symptoms of depression, the response rate was only 45%. If the kid came in at the highest end of the ADHD symptom charts with a parent with depression, what was the positive response rate? 29%. If the kid came in with an IQ below 100 and had very severe ADHD and had a primary caregiver with at least mild depression, we had a 10% chance of getting that kid better. The kids with ADHD with the worst baseline profiles, we didn't treat well enough, even though we had pretty successful treatments overall. It's depressing, but it's the real world. What do we need to do to enhance? Now, the MTA has followed up the kids in this study over now many years. Here's a graph showing that at the end of treatment, the combination treatment and the medication-only treatment, this is reducing the symptoms of ADHD. Medication worked. The behavioral treatment alone and the community treatment didn't work as well. But what happened a couple of years later? All the groups were equal. At the end of the treatment trial, everybody went into long-term follow-up essentially in the community because we weren't providing treatment anymore. Once that happened, by the 3rd year after baseline, and if I brought the graph in, this now goes out to 10 or 12 years, the initial assignment does not maintain its early benefits. ADHD is more like diabetes than an infectious illness. It probably takes some chronic treatment delivered at a good level of intensity to keep at the symptoms and impairments. Final thing before we get into a little discussion, we predicted, our team at Berkeley, some things that some of the other MTA investigators I don't think were terribly predisposed to. We said the families that show the most change in their discipline style at home will have the kids who do the best overall. Well, but ADHD is so heritable, isn't it all in the genes? Just to end with a couple of pictures, here's what we found. Here's again symptom scores of ADHD from 0 to the highest. Here's the 14 to 15 months of the study in days. A third of the families in our study didn't improve their discipline over time. They were just as negative and inconsistent as at the beginning. For them, medication was slightly better, lowered symptoms, than the combination treatment. Both of those were better than the behavioral or the community treatment. The middle third were families who showed some decent improvements in their parenting. Less negative and harsh, less inconsistent. Medication and the combination were tied. The behavioral treatment and the community were tied, but not as good. But then there was a third of the families in the study who showed, both on their self-reported discipline and on the observations we made of them in the clinic, that they had pretty dramatically improved their parenting. What happened with that group was that the combination treatment, the red line, led to symptom reduction into the normal range. So the average kid in a classroom shows about 0.7 ADHD ODD symptoms, which is the same score we got for the 50 or so families who got combination treatment and really improved their discipline. The improved family discipline mediated the normalization. These are the kids who didn't only look better than the other kids with ADHD, but they looked like the normal peer sitting next to him or her in school. What happened after the treatment ended? Parents' discipline styles reverted, and the advantage for the combination treatment went back up to the other groups. It takes maintenance of treatments to produce lasting benefits for these kids. So ADHD is not just a category in DSM. There's all sorts of developmental factors. It's on a dimension. We talked about equifinality. There's different causal pathways. We know that kids with early ADHD symptoms may do quite well or very poorly. That's multifinal outcomes, may go in different divergent paths. Treatments need to deal as much as, if not more than, academics and peer relationship skills as the attentional symptoms per se, and parents matter, schools matter, systems factors matter, because the disparities in who's even getting treatment are quite huge. So I've gone a little over an hour, and I think we'll formally stop, and then we'll do some questions, right, Julie?
Yes,
yeah,
thank you,
good.
Dr. I have some questions, but there's a packed crowd here, so we'll let people in the audience.
I wanted to know how many of these families that you studied had parents with diagnoses, especially the mothers.
So the question is, which I didn't talk about, so in this study or in other studies, how many of the parents of kids with ADHD have an ADHD diagnosis themselves? The answer, shorthand, is, if you believe the heritability statistics and sort of translate them from percentage of variance into clinical reality, 30 to 40% of parents of kids with ADHD have the symptoms themselves. So, as some consultants to us when we started the MTA study said years ago, you mean you're going to do this behavioral treatment and get your staff in the schools and do parent training, and you're not going to insist that the parents treat their own symptoms first? Are you crazy? What's the matter with you? And of course, we couldn't logistically or in terms of our randomized trial do the subset of parents and get them in treatment first, but it's a very real question. What do you have to do if you do parent training for parents, kid with ADHD? You got to teach them to be super consistent parents. Always respond with a reward. If you're going to punish, do it every time. What if you've got ADHD yourself and you're pretty irritable and your house isn't that organized? It's gasoline on the fire. So there's a very real question about how do you screen for, remember, parental depression, even mild symptoms predicted poor outcomes. Parental ADHD symptoms did not in our study, but in other studies they have. How do you identify, work through the denial? And of course, in many parents with ADHD, they never had it diagnosed because it wasn't diagnosed back then. So it's a very salient question. It's quite relevant for treatment. Julie, you go with a mic. There's people back there.
I feel very intimidated. I'm a special ed teacher, so I've dealt with the kids for 30 years in the classroom. What I'm wondering is, observing society's changes, that people don't seem to be able to wait anymore. Has there been any kind of correlation or studies about people's impatience or, I see it with the parents too. I'm not sure if I'm making this clear.
Yeah, I think you are. I mean,
Oh, good.
so maybe it's not just that all the clinicians out there are prone to diagnose ADHD. Maybe we're all less attentive. 500 channels, 5,000 channels, internet, mandatory preschool, interviews to get into the right kindergarten, multitasking. Right. As a very good op-ed in the New York Times appeared a couple weeks ago, ADHD is not just a faster society. It is a clinical syndrome, but maybe it's on the backdrop of the pressures in our society now are such that we're all not very attentive. And what are we being forced to do? And of course, then you get into multitasking. I don't think multitasking really exists. You really can't pay attention to two things at the same time. I just thought about dinner and I spaced out on what you were saying. I mean, it goes through a very, right? But some people are pretty good fast taskers. They can switch very quickly. Russ Poldrack, before he left UCLA for Texas, did a really good study about so-called multitasking, classic cognitive psych experiment. There was the group who learned wordless and the group who learned wordless and had to remember musical tones at the same time. Performance identical on the day of learning. But the wordless were not recalled long-term by the people who had to multitask first. So a lot of people may seem like they're getting it, but not have the long-term retention if you're doing too many things at once. So, I mean, that's a sociological question almost. I think it is a very different society from 50 years ago. I don't think that's the total answer for why ADHD exists the way it does now, but it's a backdrop. Sorry, we're going to go back here with the mic first, and then we'll get to you.
Sorry for keeping you from your dinner, but in your research, you showed that parents have a very important part in helping with controlling the symptoms. So were there any research on children whose parents aren't in the picture, who might be in foster care, or a guardian dies?
So there is much less research, except in a sort of almost epidemiological national health survey type, as to kids with ADHD who've been in multiple foster homes or adopted, et cetera, et cetera. We do know that kids with ADHD are much more likely to be adopted than other kids, and adoption samples are highly overrepresented with ADHD samples. You can think of all sorts of reasons why that, who gets given up for adoption, et cetera, et cetera. But we don't really know about the specific factors, except that if you think of a kid who's been in multiple transitional homes without consistent parenting and has some neurobiological risk for ADHD, it's probably not going to contribute to good outcome. So I think it's a big area to research. So let's see, Julia was right here.
My question is, you had said that when the children are in second grade is the best predictor of how they'll be by social rejection in the classroom at that time. So what if that's already happened and you're past that stage, is there a way to help a child who's past that time frame?
Right, so what do you do for social skills and for enhancing peer reputations? A study from our early summer camps back at UCLA that I didn't show you was pretty telling in that regard. So at this summer camp, we had 30 boys with ADHD, 30 comparison boys, and we did sociometric evaluations every day for the first week and then every week thereafter. How long did it take the boys with ADHD? Everybody was blinded, everybody's wearing the same t-shirts. How long did it take the boys with ADHD to get socially rejected? 3 hours. So they were 5 times more likely to get negative peer nominations by the first afternoon. What were the reasons? Their aggressive behavior. Not their looks, we rated their attractiveness, not their sports skills, not their IQ or achievement. If you're ADHD and you show that kind of impulsive aggression, you're quick to explode and react, you're likely to get teased and bullied, they want to make you react more. How do you get over that? Well, the problem is that in our study and many others, the correlation of that first day's peer rejection with the peer rejection score at the end of the summer was about 0.7. It's hard to overcome a negative peer reputation, as you all know from your friends and colleagues who don't make a very good impression the first day, and it's like no matter what, they could stand on their head and you'd still think that's kind of a weird person or what have you. We can change social skills. It takes a lot of intensive work, often group work. But that doesn't necessarily change the reputation. The reputation's the last thing to follow, because we know that you can have a group of kids in a school, some popular, some unpopular. They exhibit the same behavior, and the same behaviors looked favorably upon for the popular group and unfavorably for the unpopular group, because there's halos and reputations. Medications help with some of the impulse control problems. You don't blow out the birthday candles at the other kid's birthday as much. The behavioral treatments do better, but nothing to date has really normalized the peer reputation of these kids, because it's probably pretty pervasive stuff. So could you switch schools? The problem is you're going to form that reputation in the new school unless you have a skill set. Certainly an implication from this peer study I talked about is that if you've got the right dose of medication, if you've got an effective reward program going, don't do what some families and clinicians suggest is, let's start the school year med-free. Let's start the school year without the rewards. Let's see how it goes. Wrong idea. I think all kids with ADHD should have a medication trial each school year. I think the teacher should be blinded. I think there should be no meds, lower dose, higher dose. Don't do it to start the school year. Do it in November and March under the doctor's orders. Doctors should be trained in how to do this better, do these evaluations, because if something's working, kids with ADHD are so reactive and explosive often that the reputation will tank quickly, and then it's pretty late to play catch-up ball. Over here.
One of your slides showed up to a 3-year delay, the one by Shaw in 06 and 09.
Yeah.
Did that study or any other study replicate that? And if so, did they suggest how schooling should change in order to accommodate those youngsters, particularly boys?
Boy, good question. So if kids with ADHD are truly neurologically less mature, if their brains are going through a different developmental cycle, how do we handle that and manage that? So one school of thought would be, let's have kids with ADHD in an environment where they don't stand out like sore thumbs so much. Let's much more open classroom. Some open classrooms, everybody looks like they have ADHD, everybody's wandering around, and maybe they'll find themselves. There's not good evidence that that kind of schooling, even though it sort of masks the symptoms, really helps developmentally. My way of thinking about it, not based on great controlled evidence, is that the more structured yet warm a classroom is, like the parenting, the symptoms of ADHD may stick out for a while, but you're going to get better outcomes. Because the kid will learn, teacher means business, and I've got to stick to the rules. Now, it may mean shorter homework episodes for the kid with ADHD. What's the basis of any behavioral program? Start where the kid is and gradually shape the outcome. If the kid's aggressive 10 times a day, you don't expect 0. You expect 9, then 8, then 7. If the kid's sitting at reading circle for only 5 minutes, don't go to 20 the next day. So consistent, clear expectations. Kids with ADHD need those rewards, probably because of this reward pathway we talked about. Then the goal is gradually to taper those out so it's more intrinsically motivating. So that's my kind of clinical hunch, somewhat data-based answer to that question. It takes a lot of hard work, and you talk with families. Don't even talk to us about first grade. That teacher didn't get her. Second grade was like a haven. Warm yet structured teacher. Third and fourth grade, we're back to baseline again. Teachers make a difference. And teachers most kids with ADHD don't need to be in a special day class. But if teachers could get an undergraduate aide or two to help with the whole class, not just to be the shadow of the kid with ADHD, which might be stigmatizing, then the teacher can help deliver rewards and expectations to every kid better. So we should be teaming up public schools with universities, getting these student kids as interns to help the teachers out. If I were czar, there'd be a lot of things different, right? But it's hard work. Julie's got the mic, so I don't know where she's going to end up.
Right.
Okay, good.
So a question that touches on treatment issues. You briefly mentioned neurofeedback and said that there was increasingly positive evidence.
Right.
And folks that I've talked to that practice this absolutely positively want to engage with the child. And as a neuroscientist, one is trying to think about how actually the brain parameters are in fact being trained, or is this a side effect of being in a therapeutic caring situation?
So biofeedback, often called neurofeedback, it's very appealing. So I'm sitting at a carrel and there's a computer in front of me. And if I can only get my brain-body continuum to be regulated, then that screen's going to change colors, or I'll get a calm scene. I'm regulating my own brain waves, right? The evidence, although touted by many as convincing, has been very limited by an absence of randomized controlled trials. There's a couple of recent ones that are suggestive that this is proving beneficial. Will it stop the minute the kid gets out of the study carrel in front of the computer screen and goes back home or goes into the classroom? The problem with every treatment for ADHD is a lack of long-term maintenance and a lack of generalization from home to school or school to home, or as my buddy Howard Abakoff at NYU said, when he used to run social skills groups for kids with ADHD, they'd be great, and then the driver would come to drive the kids back home, they'd be fighting in the car because the contingencies had stopped. How do you get the mind, and in this case brain, to generalize? Can we make permanent changes? Neurofeedback isn't even at the point yet where we say it's a fully accepted treatment, and if it is, and it is the only one that provides this lasting generalized benefit, I'll be very surprised and shocked. So certainly it's in the realm of promising treatments, and a couple of recent trials are more than promising.
Yeah, back here.
Okay, yeah.
My question is, have there been any researches done or anything that, for boys who are diagnosed at an earlier age, is it more beneficial to start them in schooling later to let them mature a little later in life or longer?
Big question in most communities. How can my boy match up with that girl next door? Girls are more empathic and they're smarter, and you wait 12 years and they're getting into the Ivies and UCs, and poor boys are languishing. And now we know that the frontal lobes don't fully mature till you're almost 30, and it's my son and he's in trouble. So let's start him in first grade when he's 9, and then he'll be a great athlete and he'll be at the top of the class. I'm obviously being facetious. There's no great evidence that delaying later and later automatically leads to better improvement. A lot of kids with ADHD aren't just 6 months or a year behind. If a kid is really showing those tendencies, maybe you don't start kindergarten at age 4, depending on what the birthday cutoff is. We don't really know, because the families who might be more likely to delay may be the most concerned families, and it's correlated. There's no random assignment yet to starting kids early versus late. We do know that retaining kids with ADHD doesn't make a huge difference. They're probably going to have the same problems that second year in second grade, and so it's tempting. If it were my kid, I probably wouldn't rush to get him in, but I'd also want to get some pretty early intervention whatever year he started.
Given that the MTA studies and other studies suggest that once you stop the maintenance treatment, you revert back, or you lose some of the gains that you've made, should we as providers be suggesting to parents that we should do medication trials, off medication, trials off medications, if that's the case?
Well, as I said a minute ago, I think that even for kids who've been titrated on a good dose and we know it's working, maybe they don't need that much dosage next year. Maybe they've grown and need a higher dosage. We have just submitted to JAMA a paper from the MTA showing that across 10 years, those kids who were initially assigned a medication and who then stayed on reasonably high doses over 10 years lost about 2 centimeters in height compared to the kids who were never medicated. That's under an inch. Juvenile hall versus 2 centimeters. I know which one I'd choose, right? If it were, but there are effects of staying on medication indefinitely. No adolescents with ADHD, in my experience, relish and love being on medication. Makes them feel different, not spontaneous. So I think a well done, doesn't have to be FDA certified, but a clinical trial run by the local pediatrician in consultation with the mental health team each year. We'll see if the medication's still worth it. What about college? Kids with ADHD go on to college. Some say, I only need it for my hard classes, only need it for certain study nights. But one of the consequences, as we know, there's a wide range, but somewhere between 16 and 25% of all college students in America have tried someone else's stimulants. Usually the kid with ADHD who has sold them or given them away or what have you. And this is a public health issue because stimulants can be addictive. So anything we do has a potential cost. Let's go to some more. I'm trying to be quick with answers to get to some more. Let's go to somebody new.
I ignored this side of the room, so.
I was interested in knowing how diet can impact kids with ADHD.
Right.
And whether or not that could be replaced, or that can replace medical treatment.
So this could be a whole talk, and I had diet up as a sort of a controversial treatment on one of the early slides. So way back when there was at Oakland Kaiser, Dr. Feingold, who did the Feingold diet. Remove additives and salicylates and 70% cure rate for ADHD. Dr. Feingold never had a control group. Big problem. So for a while, very carefully controlled dietary studies were done. And to do a really carefully controlled dietary study, think about it. So the family agrees to be in the study, and the research team comes in and clears out the refrigerator and cabinets, and then puts in for a week everything with a green label on it, with the trade name covered over. Then the next week they come in and put in the red labels, then back to the green. But half the time they change the labels, they don't actually change the food. It's like a total double blind, right? When you do that kind of tightly controlled study, what's the response rate? 5%. Diet is not the magic panacea for ADHD. However, in the last 3 years, Canadian study, a good British study have shown, especially for the younger kids, 6 and 7 and under, the preschoolers, first graders with ADHD, a lot of additives in diet are correlated with ADHD symptoms. Now, is that because the families with a lot of this stuff in their family diet aren't as authoritative? It's hard to know what's cause and what's effect. I think kids in our country and everywhere should eat better. I think there's too much sugars, but I don't think this is the leading contributor to ADHD. You would hope that a sort of holistic, good behavior medication if needed, restricting what the kid eats, restricting TV and video time would all be part of the package. So based on the data, I'm not a believer that diet is the total answer, but there's some recent data to suggest that it means more than we thought it did.
I do work with young adults in college who've been diagnosed with ADHD, and many of them on meds. And I get asked, how long do I have to take these? And can we change our biochemistry? I mean, if you're on, there have been studies to say if you're on it for a certain amount of time, you can.
How long do you stay on? It's an empirical question. We don't know. What we do know is that, like all performance-enhancing meds, and stimulants are performance enhancers, you don't have to have ADHD to do better on a test with stimulants and remember more and stay up later. You have to test yourself to see. Maybe as you go from college, if it's a college student, into a job, but the job is self-employment and you've got an administrative assistant, maybe you don't need meds anymore. But maybe you need them for your primary relationship because you're so impulsive, it's hard to get along with you. Seriously. Maybe you need them for the days on your job that are the days where you're being supervised by others and not the other days. The good news about stimulants is that they're so short-acting that you can really do a trial across days and the medication kind of clears your system. It's not like the weeks-long build-up or taper down from antipsychotics or SSRIs. Some doctors will say, you got ADHD, it's a lifetime diagnosis, there's a lot of bad outcomes, stay on it forever. Even if doctors say that, the vast majority of adolescents don't stay on the medications. I think a more reasonable approach, a sort of single case experimental design, let's see how long you need them, let's try it out. But for a while during childhood and middle school, if you can keep the kid on regularly, remember, ADHD symptoms don't end when the school bell sounds. There's soccer league, there's music lessons, there's neighborhood groups, and yeah. Let's do a couple more. Yeah.
My question is, now that we have all this wonderful research and we know what we need, and so much of it has to do with socialization stuff, and looking at how the schools are categorizing and treating these particular children, what can we do, this group in here, keep cutting out, this group in here and all of the parents, to get our government and our medical profession and whoever else is available to begin to have the type of treatments available. I'm a therapist, I used to be a special ed teacher. I can do individual work with children, but that isn't necessarily going to take, I'm going to impact, maybe 10 kids?
Right.
And we need to do this, especially in California, I believe, even though our budget's cut and all these things are happening, it would make more sense just from a theoretical viewpoint to not focus so much on testing and focus on helping kids like these to be able to be successful in school. And I know that the ADHD kids are not the only ones that are square pegs trying to fit into those round holes.
Right. I mean, it's such a good point, and it's very tough economic climate after Governor Brown's announcement of just a couple of days ago as to what we're looking for: higher education, lower education, education in between, social services. And this is an issue related to policy and insurance coverage and stigma. There's still a lot of disbelief that this is an important condition, as I talked about at the beginning, and so I would amplify what you're saying. How much more, Julia? Do we have to let people go, or? Okay, good.
You talked a lot about the child with ADHD, and you did mention that changing parenting styles can have a major effect on the behavior of a child with ADHD or ADD. My question is, where does the parents of all this fit in? I mean, how does the parent find out how to change its behavior? Are there classes? Are there books? I mean, where do you, that it made such a big difference, but I'm not sure how where's the roadmap for the parent who has one of these childs to make some of these changes?
There are classes right here at the Mind Institute.
Oh, okay.
There are a growing number of practitioners. The Bay Area is languishing behind LA, New York, and some of this. There's a growing recognition of the need for these kind of structured behavioral treatments for kids like this. And if all else fails, go to an advocacy group like CHAD, Children and Adults with ADD, and the local chapters have the resources in the community vouched for by families who've been through this. And I think you got to do some grassroots stuff and to see who's really with it in a local community. And of course, there's a need for more concentrated policy, insurance, getting ADHD sometimes a pre-existing condition not covered, all kinds of stuff like this. So I think we have to stop, although we were just getting rolling. So
I'd like to thank everybody for coming out tonight and your excellent answers. We appreciate it.
The UC Davis Mind Institute began in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, learning disabilities, and other brain disorders is helping children achieve their fullest potential. Please call or visit our website to find out more about current studies, our research team, and upcoming events.